It happens in the moments you least expect it. Extubation goes smoothly. Patient is breathing. You remove the tube. Then, silence. Not the good kind. The chest is moving, but no air is going in. SpO2. 94. Then 88. Then 79. You have seconds, not minutes, seconds. Laryngospasm is the most common serious airway complication in anesthesia, and it will find you when your guard is down. I'm Anesthesia Buddy, and today, laryngospasm. Let's get into it. It's a routine case, 28-year-old female, healthy, no significant history, coming in for a laparoscopic appendectomy. Surgery goes perfectly. You reverse the neuromuscular blockade, train of 4 ratio adequate, patient breathing spontaneously. You suction the oropharynx, a little bit of blood-tinged secretions. You deflate the cuff, remove the tube. She takes 1 breath. Then nothing. You watch the chest. It's moving, but there's no air movement. SpO2, 96. You apply a face mask, positive pressure, can't ventilate, complete obstruction. SpO2, 91. You place an oral airway, jaw thrust, head tilt, still nothing going in. SpO2, 84. Heart rate climbing, 118. SpO2, 76. This is not secretions. This is not laryngeal edema. The vocal cords are clamped shut. This is laryngospasm, and it is not going to resolve on its own. Laryngospasm. Involuntary sustained closure of the vocal cords caused by reflex contraction of the laryngeal muscles. A protective airway reflex gone catastrophically wrong. How does it happen? The larynx is one of the most sensitive structures in the body. Any irritant at the level of the vocal cords during a light plane of anesthesia can trigger this reflex. The most common triggers? Secretions or blood contacting the vocal cords. This is why you suction before extubation. But suctioning itself can be the trigger. Extubation at a light plane of anesthesia, the most dangerous zone. Deep enough to have lost protective reflexes, light enough for the larynx to be hyperreactive. Extubate deep or extubate awake, never in between. Airway instrumentation, laryngoscopy, LMA insertion or removal, oral airway placement. Regurgitation or aspiration, gastric contents hitting the cords. Pain or stimulation. Any noxious stimulus during a light plane can trigger it. Children are at significantly higher risk than adults. Their laryngeal reflexes are more sensitive and more reactive. Upper respiratory infection in the preceding weeks dramatically increases the risk. The pathophysiology. External branch of the superior laryngeal nerve plus the recurrent laryngeal nerve drive the reflex arc. Adductor muscles of the larynx contract forcefully. True and false vocal cords slam together. Complete glottic obstruction. The patient tries to breathe. The chest moves. Nothing goes in. If unresolved, hypoxia worsens rapidly. Hypercarbia builds. Bradycardia from hypoxic vagal response. Cardiac arrest. Negative pressure pulmonary edema can develop after laryngospasm resolves. The patient has been generating massive negative intrathoracic pressure against a closed glottis. Fluid is pulled into the alveoli. This is post-obstructive pulmonary edema. Watch for it even after successful treatment. You have laryngospasm. SpO2 is dropping. Here is exactly what you do, right now, in order. Step 1. 100% oxygen. Tight seal face mask. High flow oxygen. Even if you can't ventilate effectively, maximize the FiO2 at the airway. Step 2. Continuous positive airway pressure. Apply firm, continuous positive pressure with the bag. Do not give rapid, repeated squeezes. Sustained, gentle, positive pressure can sometimes break a partial laryngospasm by forcing the cords open. Assess for air entry through auscultation, ETCO₂ tracing, reservoir bag movement, and condensation in the mask. Step 3. Deepen anesthesia with propofol or a volatile agent, for example, sevoflurane, and continue to ventilate with 100% O2. Step 4. The Larson maneuver. This is your first-line physical intervention. Bilateral firm pressure into the laryngospasm notch, the space posterior to the earlobe, anterior to the mastoid process, at the base of the skull. Apply firm inward and anterior pressure bilaterally simultaneously. This stimulates the facial nerve, causing reflex relaxation of the laryngeal muscles. Press hard. This is not gentle. It should be uncomfortable even to perform. Many providers don't press firmly enough. If it's not working, press harder. Step 5. Succinylcholine. If the Larson maneuver and CPAP are not breaking the spasm and SpO2 is dropping below 88%, this is your pharmacologic rescue. Low-dose succinylcholine, 0.1 to 0.5 milligrams per kilogram IV, will relax the laryngeal muscles and break the spasm within 30 to 60 seconds. Full-dose succinylcholine, 1 to 1.5 milligrams per kilogram. If the patient is heading toward cardiac arrest from hypoxia, don't hesitate. Paralysis and intubation is better than hypoxic arrest. Step 6. Ventilate and oxygenate. Once the spasm breaks, positive pressure ventilation. Get the SpO2 back up. Step 7. Decide about reintubation. If the patient is deeply hypoxic, hemodynamically unstable, or the cause of laryngospasm is still present, reintubate. Step 8. Watch for post-obstructive pulmonary edema. After the laryngospasm resolves, listen carefully to breath sounds. Frothy pink secretions from the ET tube or crackles bilaterally, post-obstructive pulmonary edema. Treat with PEEP, diuresis if needed, supportive care. The board questions hiding in this crisis. Question 1. What is the most dangerous plane of anesthesia for laryngospasm? The light plane of anesthesia. Too light for protective reflexes, too deep for the patient to cooperate with the airway. The clinical rule: extubate deep or extubate awake, never in the middle. Question 2. What is the Larson maneuver? Bilateral firm pressure into the laryngospasm notch, posterior to the earlobe, anterior to the mastoid process. Stimulates facial nerve, reflexively relaxes laryngeal muscles. Question 3. What complication can occur after laryngospasm resolves? Post-obstructive pulmonary edema, also called negative pressure pulmonary edema, caused by massive negative intrathoracic pressure generated against a closed glottis. Fluid is pulled into the alveoli. Watch for it. Treat it early. Question 4. Which patient population is at highest risk for laryngospasm? Pediatric patients, especially those with a recent upper respiratory infection. Their laryngeal reflexes are significantly more reactive. Consider delaying elective surgery for 4 to 6 weeks after upper respiratory infection. Laryngospasm. It happens fast. It looks like other things first, and it does not wait for you to figure it out. Laryngospasm is preventable more often than it is treatable. Suction before extubation. Wait for an adequate plane. Know your patient's risk factors before you ever pull that tube. The best laryngospasm management is the one that never has to happen. If this helped you, share it with someone in clinical rotations right now. Subscribe to Anesthesia Buddy, because the best time to learn this is before you need it. I'm Anesthesia Buddy. Stay sharp. See you in the next one.